Hello. Good evening. Welcome you all to the monthly webinar of the International League Against Epilepsy, Eastern Mediterranean region. I am happy really to introduce the first lecturer today, Dr. Sonia Khan, MD, FRC, consultant adult neurologist and epileptologist. She is the head of the Epilepsy Division, Neurology Department, Prince Sultan Military Medical City. She is a former associate editor of neuroscience journals and former director of clinical neuroscience, also former president of Saudi Epilepsy Society and Saudi chapter of Epilepsy 2005 to 2013. Graduate at King Saud University Medical College in 1987. Joined King Faisal Specialist Hospital and Research Center at Department of Internal Medicine in 1988. Joined Hammerschild Hospital, London, Department of Internal Medicine, 1989. MRCB Internal Medicine, 1992. Joined the Riyadh Military Hospital in Neurology Division as Fellow in Adult Neurology, 1992 for 4 years. Adult Epilepsy Fellow at Epilepsy Comprehensive Program, Reid Institute at UCLA, Los Angeles, California. Fellowship Royal College in Edinburgh and Fellowship Royal College in London. Main interest epilepsy in women, epilepsy surgery and genetics and epilepsy. So Sonia Khan, please.
I would like to thank the organizers for this invitation to participate in the meeting. My task is to provide an overview on drug-resistant epilepsy. We know that between 25% to 30% of epileptic patients are pharmacoresistant, and this fact affects their quality of life. Therefore, it is very important to identify those patients in order to reduce the burden of seizures in their life and to identify early surgical patients for epilepsy surgery or identify patients for alternative methods of treatment. The International League Against Epilepsy defines drug resistance as failure of adequate trials of two tolerated appropriate choices of antiepileptic medications, whether in monotherapy or in polytherapy. To provide sustained seizure freedom. The choice of the two antiepileptic medication was determined because we know that the addition of any third or additional antiepileptic medication can improve the seizure control in almost 3%. As you can see, and 35 or 36% of patients remain pharmacoresistant. The frame of definition of the International League Against Epilepsy for pharmacoresistant or drug-resistant epilepsy comprises two levels. Level 1 is categorization of outcome to a therapeutic intervention, which provides a general template or scheme to categorize the outcome to each therapeutic intervention. What does that mean? That means if the patient is seizure-free, what do you mean by seizure freedom? i.e. sustained seizure freedom and for what time or what duration. Failure of antiepileptic medication means the patient fails adequate antiepileptic drug trial, and we have to identify the duration of the trial to determine whether it's a true drug failure or no, and seizure reduction or undetermined also that can be determined by the antiepileptic drug choice and the duration of the antiepileptic drug. The adequate time frame to determine any of these outcomes is considered by this definition into an interval which is equal to 3 times the interval between initiating the antiepileptic drug and achieving seizure freedom. And in general, it's approximately 1 year. From level 1, we move to level 2, which is the definition of drug resistance. And this provides the core definition of drug resistance. And we should provide the informative trials and the number of those trials that has been used to determine the treatment failure. Before we determine the seizure resistance to antiepileptic drugs, one has to remember that there are causes of apparent or false pharmacoresistance. This includes the misdiagnosis of epilepsy. For example, patients with psychogenic non-epileptic seizures can mimic pharmacoresistance. Misdiagnosis of epilepsy type, for example, the misdiagnosis of temporal lobe seizures for absence seizures, and therefore to choose something like carbamazepine, which can worsen the seizure. 3, inappropriate assessment of response or lack of response. For example, overlooking the drug interactions or increased side effects or decreased tolerability of medication. Inappropriate dosage, suboptimal therapeutic level can lead to false drug resistance. Inappropriate patient behavior with lack of sleep or poor compliance to medications also can lead to false drug resistance. Those are a few etiologies of epilepsy mimickers, i.e. what looks like they have spells and they look like seizure, but actually they're not, including syncope, hypoglycemia, migraine, sleep disorder, panic attack, psychogenic events, and others. So it is important to remember those causes as differential diagnosis of spells and to differentiate them from epileptic seizures to provide the appropriate management. What epileptic syndromes are usually drug resistance? In a significant result of a remarkable study of a cohort of children with epilepsy that has been followed for over 30 years to adulthood, it has been shown that almost 78% of patients with symptomatic generalized epilepsy, 50% of patients with symptomatic focal epilepsy, and 13 patients of the so-called idiopathic or genetic generalized epilepsy were refractory. The category of catastrophic epilepsy of childhood, including different types of epileptic encephalopathies and localization and some localization related epilepsies were specially found to be drug resistant. Example, the voltage-gated ion channelopathies like the sodium channelopathy. The classical example is Dravet syndrome. The calcium channelopathies and some subtypes of the potassium channelopathies can be drug resistant and can cause catastrophic epileptic encephalopathies. Another classical example of catastrophic epilepsy with severe drug resistance is Lennox-Gastaut syndrome, which is characterized by multiple seizure types, specific EEG pattern with a slow EEG background, generalized slow spike wave discharges, multifocal discharges, and fast activity during sleep with progressive cognitive impairment with an age onset of around 2 years. What are the patterns of drug resistance? The drug resistance could start from the beginning with a de novo drug resistance. So it can be from the onset and the patient never achieves seizure freedom. Delayed resistance, i.e. when the patient is initially seizure free, but he has recurrent uncontrolled seizure at a delayed intervals. Fluctuating patterns when the epilepsy alters between being controlled to uncontrolled. Number 4, the initial drug resistance, and then it becomes drug responsive. Now, is it important to identify drug resistance? The answer is yes, because the presence of drug resistance can influence different factors and in influence several factors that lead to reduced quality of life, can alter mood and personality changes, can lead to educational and social consequences, neurochemical changes with drug side effects, and the persistence of seizures and the subsequent complications of that, and the very important increased risk of sudden death. Quality of life. Depression is common in epileptic patients. Depression is more common in patients with active epilepsy, as they have reduced quality of life, and the seizure control was the most important measure that can lead to depression. Seizure freedom has greater influence on quality of life than the reduced frequency or seizure reduction. Depression has greater negative impact on human life and quality of life than the seizure frequency, and it is found to be almost 2.7% among the epileptic population. And of course, the drug side effect and employment as negative factors on the quality of life of epileptic patients. Now, for those patients with drug resistance, they have lower quality of life than patients with controlled seizures. Quality of life in seizure-free patients is very important to mention that it is similar to those without epilepsy. And the affection of quality of life is not only among patients, but also among the caregivers. SUDEP, or sudden unexplained death. This is a recognized syndrome when a patient with epilepsy dies suddenly with no other etiology found for death. The prevalence is around 1 to 1,000 per year. And for those patients with drug resistant, it increases to 100 to 300 per year. So this is the most important factor for developing of sudden death. And the most accepted mechanisms for sudden death in epilepsy is related to the alteration of the cardiac control, the neurocardiac control or the neurorespiratory control with apnea and arrhythmia and asystole. Young patients with generalized tonic-clonic seizure, poor seizure control, abrupt and frequent changes in medications, poor compliance, alcohol, patients with many seizures not recorded in medical notes, and patients who had nocturnal seizures are important risk factors. What are the potential mechanisms of drug resistance? The etiology of the disease, whether it's a channelopathy or, for example, patients with focal cortical malformation, genetic factors, comorbidities, inflammatory processes like patients with autoimmune epilepsies, other factors, including the alteration of the blood-brain barrier, the drug-related factors with tolerance, pharmacokinetic alteration, drug efflux transporter alteration, drug target alteration, alteration of the network, of the epileptic network, worsening of the epileptic patterns, and epileptic seizures. Some of the proposed hypotheses for possible mechanism of anti-epileptic drugs. The pharmacokinetic hypothesis reflects the overexpression of drug efflux transporter in the peripheral organs, leading to reduction of the plasma level of anti-epileptic drugs and less amount of those medication cross the blood-brain barrier. The neuronal network hypothesis represent the consequence of seizures with induced degeneration and remodeling of the neuronal network that lead to altered excitatory and inhibitory responses. The intrinsic severity hypothesis related to common neurobiological factors that leads to epilepsy severity and pharmacoresistance. The gene hypothesis, gene variant hypothesis, reflects the variation in the genetic expression associated with pharmacokinetic or pharmacodynamics of anti-epileptic medication that can lead to inherent pharmacoresistance. This include genes that control the metabolic enzymes, the ion channels, and the anti-epileptic neurotransmitters. The target hypothesis reflects the alteration in the antiepileptic synaptic targets. For example, the voltage-gated neurotransmitter receptors, the GABA-A receptors, the glutamate receptors, etc., leading to reduction in drug sensitivity and refractoriness. And the transporter hypothesis with overexpression of the anti-epileptic drug efflux transporter, minimizing the amount of anti-seizure medication that can reach the brain. What are the risks of seizure recurrence? The presence of epileptiform or focal abnormalities on the EEG, focal or cortical or limbic abnormality on brain MRI, additional factors for increased seizure recurrence after stopping antiepileptic medications, including the multiple seizure types, the high seizure frequency, the longer duration of epilepsy before control, and the shorter duration of seizure freedom. Now, what are the epileptic patterns in general? There is several patterns, namely for the remittent, i.e. those who start to have seizures, but they remit completely. This includes some of the potassium channelopathies, like the benign familial convulsions with neonatal seizures at birth, which remits by themselves. Some of the absence seizures, like childhood absence epilepsy, the non-remittent drug responsive, like juvenile myoclonic epilepsy, which respond very well to antiepileptic medication, but you have to continue treatment in many of those patients for life. Non-drug responsive but treatable, many of those patients are those with focal or localization-related epilepsy, and the poor responsive and pharmacoresistance, like Lennox-Gastaut syndrome. Clinical features in a nutshell: the early onset presents in status epilepticus, abnormal neurological examination, the focal seizures at diagnosis, mixed seizure types, developmental delay, multiple seizures before treatment, seizure clustering, and the presence of structural lesions. This is a recent review on pooled analysis of risk factor for drug resistance epilepsy. And the most important factors for drug resistance, again, the confirmation of the of the EEG abnormality with the presence of slowing epileptiform activity or the development of status epilepticus, the multiple seizure types, and the presence of febrile seizures. What about the predictors of drug resistance epilepsy development after convulsive status epilepticus? Now, it is important and common to have drug-resistant epilepsy and after as a sequela of convulsive status epilepticus. However, little is known on the early prediction of drug-resistant epilepsy after convulsive status epilepticus. This is a review of 140 patients with convulsive status epilepticus admitted in a tertiary care hospital between 2008 and 2015, with revision of their demographic, clinical features, serum albumin, MRI, EEG characteristics were collected and analyzed using the multivariate logistic regression. And after a long follow-up of 62 months, 91 patients were enrolled and revised. The history of epilepsy, longer status epilepticus duration, cortical or hippocampal lesions on MRI are early predictors of the development of drug-resistant epilepsy after convulsive status epilepticus. How to approach drug-resistant epilepsy? We will mention about changes in the how to change anti-epileptic medications, but after we confirm the diagnosis of drug resistance, as I mentioned earlier, the introduction of a new medication has limited value. So other options include surgery, whether focal resections, hemispherectomies, callosotomies, etc. Others include ketogenic diet, some of the newer experimental drugs, brain stimulation, and immunotherapy. I would like to remind you that certain anti-epileptic medications can aggravate seizure control, and therefore it can give false the image of false image or the impression of false resistance, like carbamazepine, which worsen the absence seizures and the myoclonic seizures. Also, it can worsen Dravet syndrome seizures, and the same for gabapentin, which can worsen the myoclonic seizures, etc. So the choice of the antiepileptic medication is very important. Now, this is a recent meta-analysis of pivotal trials on efficacy of antiepileptic medications, newer antiepileptic medication as add-on in resistant epilepsy. As you can see, there is no significant difference among different drugs that has been used in this meta-analysis and evaluated in this meta-analysis, including eslicarbamazepine, ezogabine, gabapentin, levetiracetam, lacosamide, prampanel, pregabalin, tiagabine, topiramate, vigabatrin, zonisamide. And the highlights of this meta-analysis indicated that all these 11 antiepileptic medication had greater seizure response to placebo. Pregabalin, tiagabine, vigabatrin had the highest pool in seizure reductions. Ezogabine, levetiracetam, vigabatrin had the highest pool for seizure freedom. However, patients were likely to discontinue these medications because of side effects, except for pregabalin in comparison to placebo. So, despite the guidelines on antiepileptic medication according to the seizure type, whether focal or generalized, and the introduction of many newer antiepileptic medications, most of these medications, they have similar efficacy, and the value for adding a third medication is around an improvement of seizure control does not exceed 4%. Now, it is impossible to predict which antiepileptic medication to be effective in selected patients as an initial therapy. And in the routine clinical practice, we don't have a surrogate biomarkers to detect the seizure response or detect the risk of drug resistance, which lead us to the approach with success and error in the management and the choices of antiepileptic medication, with subsequent significant time delay of other treatment options, such as delaying surgery, which become less effective if it was significantly delayed, and further leads to reduction in the quality of life, loss of productivity, and increased mortality. With this, it leads me to the introduction of the concept of personalized treatment in epilepsy, which is a promising type of management strategy in the future, where you enter in a specialized software the data of the patient, the epileptic features of the patient, plus blood results, blood sample and RBC analysis that looks into the genetic, the HLA typing, and other features that can lead to identification of the phenotype of the epileptic condition the patient has, and the appropriate selection of anti-epileptic medication, which is a future type of epilepsy management that can significantly improve the choices of anti-epileptic medication. That was a treatment that we hope we can reach in the future. Meanwhile, what shall we do with our pharmacoresistant epilepsy? Especially that we know that addition of newer anti-epileptic medication has its limited value. One of the important treatment strategies is the referral to epilepsy surgery. Which patient to be referred? Those are the patients who are drug resistant with uncontrolled to medical treatment, failure, as we mentioned earlier, of 2 anti-epileptic medication, the patient, they have disabling seizures or they have side effects, or the patient who has a surgical lesion or epileptic lesion on the brain, such as patients with hippocampal sclerosis, as significant number of those patients, or the majority of these patients, represent pharmacoresistant temporal lobe epilepsy in adult, up to 60% or more in patients, to cavernomas or other vascular malformations, cortical malformations like focal cortical dysplasia, and developmental tumor like gangliomas and DNETs are commonly associated with pharmacoresistance. What are the confirmatory procedures for epilepsy surgical candidacy? The basic confirmatory diagnosis and cause of epilepsy, to consider the additional antiepileptic medication so that we can at least satisfy the failure of 2 antiepileptic medication trial, present the data of the patient in the surgical conferences in the epilepsy monitoring unit, to evaluate the need for intracranial recording or intraoperative functional mapping under awake craniotomy, and the modification of the surgical strategies by our surgical colleagues. And as you can see, with this confirmatory procedure to reach a decision about epilepsy surgery, it's an overlap between different investigations and different departments: neurology, epilepsy, neurosurgery, neuropsychology, and neuroradiology. So this is a brief schema that shows you how we do presurgical evaluation. If we have pharmacoresistant or drug-resistant epilepsy with a lesion that's seen on the MRI, we proceed to what the so-called phase 1 non-invasive EEG studies to confirm that that lesion is responsible for the pharmacoresistant epilepsy, and that all the data the patient has is concordant. So we can perform the standard MRI, EEG, and video EEG to record the seizures to see they are concordant with the lesions. Additional functional neuroimaging in the form of ictal and interictal SPECT scans, interictal PET scans, and magnetoencephalogram can be performed. And if we confirm the concordance, we can proceed directly to epilepsy surgery, whether with electrocorticography or no, according to the type of the lesion. And if the lesion is near the visual field, or it can, if resection can endanger the vision, visual fields before surgery can be performed. If the patient has no clear lesion on the MRI, or the patient has epileptic, multifocal epileptic types of seizure, there is indication to perform phase 2 or invasive recordings using the depth electrodes and the intracranial strips and grids, and to determine the availability or the of one epileptic focus, and we can perform the resection accordingly, and of course to evaluate eloquent cortex, etc. Now, if there is failure of identifying a single focus, or it is difficult to resect the lesion, the patient may be considered as not suitable for curative or palliative epilepsy surgery, and we can proceed to other type of treatment modalities, such as neurostimulation, vagal nerve stimulation, or other modalities like corpus callosotomy for patients with tonic seizures and Lennox-Gastaut syndromes. So those are the types of epilepsy surgery that commonly performed: lesionectomies, like frontal lobectomies, anterior temporal lobectomy, focal corticectomy in other parts of the brain, selective amygdalohippocampectomy, lobectomies, and multilobar resection, depending on the types of the seizure. And if the data, epileptic data that has been obtained from the presurgical evaluation are concordant, and if the epilepsy surgery is performed proper, then there is a significant improvement in the quality of life in those patients. For example, patients with mesial temporal lobe epilepsy, if we compare the medical and surgical outcome in a double placebo-controlled trial, you can see the significant difference at the end of 1 year between the patients who had surgical treatment and they improve in 6 out of 100 patients, while patients with medical treatment, only 1 in 100 patient improve with a significant difference. Also, non-randomized clinical trials confirmed the maintenance of the significant improvement of quality of life in the surgical limb in comparison to the medical limb. How about other types of surgical treatments? This includes the disconnective and palliative surgery. Hemispherectomy is whether anatomical or functional, is indicated for those patients who has a strictly unilateral hemispheric lesion like hemimegaencephaly or other lesions like ischemic infarctions, etc., where they can perform the hemispherectomy with disconnection. Corpus callosotomy is another procedure that is it's a palliative procedure that's performed for tonic seizures. Multiple subpial transection is indicated as a palliative therapy for patients with lesions in eloquent cortex, and vagal nerve stimulations for patients with none suitable for epilepsy surgery, especially if they have bilateral diffuse lesions like cortical malformation or patients with Lennox-Gastaut syndrome or other lesions. Brain stimulation, whether vagal nerve stimulation is the most popular, transcranial magnetic stimulation, intracranial stimulation, including surface electrodes, which is a responsive neurostimulation, or deep brain stimulation, DBS, which can stimulate the hippocampus, or the most commonly target is the anterior thalamic nucleus and the cerebellum. As you can see, this illustrates the different types of neurostimulation. Now, the vagal nerve stimulation has achieved class 1 level C evidence for as an indication for pharmacoresistant epilepsy in children and in adults for those patients who are not surgical candidates. The differences between the different types of stimulation, that probably the neurostimulation and the DBS are more invasive than vagal nerve stimulation. They are reversible. All of them, they have achieved class 1 evidence in favor. Now, for the vagal nerve stimulation and for the deep brain stimulation, we don't need to identify the epileptic focus. However, in the responsive neurostimulation, it is the electrode is better placed or is placed in the focus. Now, many patients, they can have a multifocal epileptic foci, so they introduce the stimulating electrode in the active focus, and it can improve the seizure control. The efficacy has been shown to be significant in both vagal nerve stimulation, RNS, and DBS. Some side effects for vagal nerve stimulation as throat symptoms, and the neurostimulation and others is, and the other thalamic is because of the complications that can occur due to the implantation, and the risk of depression is higher with thalamic deep brain stimulation. Ketogenic diet is another modality, and in principle, it replaces carbohydrate in the diet with fat, with different types of saturated fat, so that it can alter the fuel that reaches the brain from glucose to ketones, which can enhance the synthesis of glutamine, which is the precursor for the inhibitory neurotransmitter GABA in the brain. And the ketogenic diet has been approved as an adjunctive treatment for patients with pharmacoresistant epilepsy in children. As in this study, 90% of patients achieve seizure freedom in 7%, more than 50% reduction in 38, and less than 50% in 62%. So it's an important adjunctive modality of treatment. Certain epileptic syndromes, like the glucose transporter type 1 or GLUT1, which reflects the deficiency in the transporter protein that transport glucose into the CSF, can be pharmacoresistant can have seizures. Patients can have seizures, which is pharmacoresistance from early onset in life. The patients are usually in the pediatric age group, and commonly they have microcephaly. The CSF shows low CSF glucose, and it has been well-established association to the CLC2A1, which is the GLUT1 gene deficiency that lead to the this glucose transport deficiency. And the treatment of choice in this condition is ketogenic diet. Another etiology for autoimmune, for pharmacoresistant epilepsy is the autoimmune encephalitis and the autoimmune epilepsy, related to intracellular antigen or surface antigen antibodies that can develop due to these antigens as a consequence of cross reaction or cross immune reaction to pathogens like infection or tumors. And some of these antigens are associated with tumors, like the amphiphysin, and so many of them which are more common to be associated with autoimmune epilepsy, like the LGI1 protein, the NMDA receptor antibody encephalitis, and the GAD65 autoimmune encephalitis are less commonly associated with malignancy or tumors. They have certain clinical features, which I don't need to go over this busy slide, but many of these patients with autoimmune epilepsy, they start with refractory onset epilepsy associated with a progressive neurological and neurocognitive impairment. And the early identification of these patients is very important because it can lead to the early introduction of immune suppression, including steroids, IVIG, plasma exchange, or other modalities such as rituximab and others that can improve the outcome. This is an example of a patient with LGI1 antibody encephalitis that presented to us with progressive she's 32 years. She presented with progressive depression for 3 months, followed with recurrent generalized tonic-clonic seizures and left facio-brachial tonic seizures, as you can see on the EEG, with suppression on the right hemisphere when at the onset of the brief facio-brachial seizure. Her MRI has shown a right hippocampal swelling with diffusion restriction and active FDG PET, indicating an active epileptic focus. The patient had the autoimmune panel was sent, and it was positive for LGI1 from the serum and the CSF. Patient was treated with immune suppression, and she showed improvement. Another etiology of drug-resistant epilepsy is the genetics. And as you can see in recent year with the advanced genetic modality detection, there are many genes that has been discovered associated with epileptic conditions in children and less common in adults, including the channelopathies and others. Why is it important to do genetic studies in pharmacoresistance when it is indicated? Because these genes can influence the therapeutic response, like the SC1A, which is the Dravet syndrome. They get worsened with phenytoin and lamotrigine, while the SCN2A, they can respond to high dose of phenytoin. For example, the tuberous sclerosis gene, when it is positive and the patient has tuberous sclerosis, the treatment of choice is, in addition to other modalities, is to add everolimus to the treatment, etc. With this, I conclude my presentation that despite pharmacoresistance that can occur in almost 30% of epileptic patients, epilepsy remain a treatable condition. And identifying the etiologies and the potential treatment strategies can lead to a better life. And many patients can lead a normal life with healthy quality of life when treated appropriately and followed appropriately. And I remind everybody, including myself, that epilepsy should not be treated as a social taboo, and we should all work together to improve the quality of our patients' life. Thank you.
Thank you very much, Dr. Sonia, for this nice and informative lecture. I think we left a good time for us for some questions. To start with, I can ask before about the polytherapy. It is said that polytherapy itself can play a role in the emergence of refractoriness in treatment of epileptic patients, those with multiple therapy, I mean 3, 4, or 5 drugs.
What I meant by this presentation, the introduction of a third anti-epileptic medication after the failure of 2 anti-epileptic medications, whether they were given when they should be appropriate, whether they were given as a turn and consequence, or they were given together. So after giving the third medication, the chance of improvement of seizure will not exceed 4%. Yani it's a matter of a failure of 2 medication can give you a clear indication that you have a pharmacoresistance, provided that you're giving the patient the suitable medicine. And when you introduce second medication in polytherapy, appropriate interactions, that there is no negative interactions between the 2 medications. For example, introducing carbamazepine and phenytoin together. And this is not appropriate. So if you give 2 medications and they are appropriate, and the patient fails these medications after adequate antiepileptic drug trials, the third medication will increase the seizure freedom more than 3 to 4%. This is what I meant.
Yes, that's true. But I mean, if you delay the introduction of more than 1 drug, you will delay the emergence of refractoriness as a general rule. Anyway, questions of our audience, one of them, the first one, what is the frequency of epilepsy and depression?
Now, there is a reciprocal relation between depression and epilepsy. Depression, as I mentioned in the presentation, is quite common in epileptic patients, but also, although I don't have the exact figure of how much epilepsy percentage of patients of depression they can have epilepsy, but definitely depression itself is a risk factor for the development of epilepsy. And for those patients who are who have active depression and they're not on treatment, the risks of developing epilepsy is higher than depressed patients who are receiving treatment or the general population. But I don't have the exact figure.
Okay. When should we consider, Dr. Sonia, the diagnosis of autoimmune epilepsy when we have a drug-resistant epilepsy?
Now, that's a very interesting question. Now, in recent years, the introduction of the concept of autoimmune epilepsy has solved the mystery of many of those patients with epilepsy of unknown etiology. Because there is a considerable number of those patients. If you do the autoimmune panel in the serum or in the CSF, they have positive results. And a subset of these, they don't have a positive result, but they're still considered as autoimmune. In general, the clinical features that suggest that this patient could have an autoimmune epilepsy is the de novo appearance of pharmacoresistant epilepsy from the beginning, after a period of behavior or cognitive decline. Like the patient I presented, although that patient had the classical or the pathognomonic brachiocephalic seizures, tonic seizures, but some other patients or other types of autoimmune epilepsy, they don't have this particular seizure type, but the presence of a cognitive deterioration without any antecedents. Patients start to have behavioral, cognitive, mental, psychiatric manifestation, followed or accompanied by pharmacoresistance epilepsy is highly suggestive of autoimmune epilepsy. Now, recently, 2 scores has been introduced. One of them is a clinical score called the EP2, where they look at different items, including the age of onset, the type of the seizures, the EEG changes, the seizure types, and many other CSF results, etc. And when you see these, if a patient scores significantly on that, even if the antibodies are negative, it's likely or a high possibility that this patient has autoimmune. And also it will help in the management. So in general, behavioral changes with pharmacoresistance, de novo appearance of all this is suggestive of an autoimmune. And some autoimmune epilepsies, they have their signatures. For example, the NMDA receptor antibody, they have the orofacial dyskinesia, they have the delta brushes on the EEG, in addition to the pharmacoresistance, etc., and the limbic encephalitis or the limbic MRI changes in the LGI, for example, with the brachycephalic seizures. But in general, this is the features.
Thank you. An interesting question: how early after commencement of AIDS can we make a diagnosis of drug-resistant epilepsy?
When can we say, just to make sure that I understand the question, when can...
How early? Yes.
How early, yeah. You see this, what the objective of the definition of pharmacoresistance by the International League Against Epilepsy made life easier for the early identification of patients with pharmacoresistance. For example, if you have a newly onset epilepsy and you decide to start treatment, now you have to look at of course, you choose the right medicine. You have to give the doses, and most of the drugs we go in escalating fashion. We don't give the patient high doses from the beginning. And we monitor the patient regarding the drug response and the tolerability of the medicine. And then we see if the patient responds or not. Now, according to the ILAE, you need, when the patient becomes seizure-free, you need in that definition 3 times that interval to say definitely that patient has responded to treatment or he did not respond, so you can either switch or you can add. Approximately, it's a year to say probably that you tried 1 medication or probably 2 medications. I would say 2 satisfactory trials of medication before you can say that this patient is pharmacoresistant. But this is a general concept that there is always exception for this. For example, if I have a woman who is at the childbearing age, and the patient comes with a classical history of hippocampal sclerosis, including the appearance of the lesions on the MRI, and I tried her on 1 single drug, for example, adequate doses of carbamazepine, which is a very good medication for this condition. And if I reach a high dose of the medication and the patient still has seizure, I know by definition that this condition is pharmacoresistant in 60 to 70% of patients. So probably I will refer this patient for epilepsy surgery earlier than trying a second drug. The same is true for those patients who have, for example, a tumor, a cavernoma, who is pharmacoresistant from the beginning, having frequent seizure, despite good doses of appropriate antiepileptic medication, even if it's a single one, because they have surgical lesions. So probably if they fail the first medication, I think it's fair to send them for epilepsy surgery to minimize the morbidity, improve quality of life, and of course, to shorten the period reaching epilepsy surgery.
Do you think that cannabinoids could help in the refractory seizure?
Yes, cannabinoids, this is, although I personally, I have no experience with that. As you know, it's not available in the Kingdom of Saudi Arabia. Cannabinoids are a new modality, and there's the synthetic cannabinoid and the others.
They has proven their value in epileptic encephalopathies like Lennox-Gastaut syndrome, in Dravet syndromes, and others. But there is restrictions, and there are FDA regulations in the United States, and there are so many other, I would say, rules regarding this cannabinoid, which I'm not the expert to talk about it. But yes, it's a new modality or a new anti-epileptic treatment for pharmacoresistant, certain type of pharmacoresistant epilepsies, yes.
Thank you. An obscure really question, I don't know, in patients with resistant from the start, I hear one of the audience ask, do you start with monotherapy or polytherapy? I don't know what he means by from the start.
Well, you see, if you have an untreated patient, epileptic patient, whether you cannot say that the patient is pharmacoresistant if you do not treat the patient. And you don't try the appropriate medications, let's say two antiepileptic medications, or at least one antiepileptic medication if you had a surgical lesion. So I think we'll start from the beginning with one single medication, appropriate increase, and then you follow the schema that is being suggested by Kwan and Brody, that you give the patient one medication, you increase the doses appropriately, you follow the response, and you follow the tolerability. And if the patient fails that medication that was a trial that shows failure of seizure control, either you switch to second medication and it should be again suitable, or you add the medication, which provides a good response in that particular epileptic condition, and to ensure that there is proper interaction or no negative interaction with the medication which is there. Now, if you give these two medications, that's the time when you have two medications. But I'll be a little bit reluctant to start two medications unless you're telling me something about certain epileptic conditions. For example, Lennox-Gastaut syndrome. Then, as you see, it's an electroclinical diagnosis. So from the beginning, if I see a patient with Lennox-Gastaut syndrome, very unusual that this patient will be seizure-free on one medication, but keeping in mind the issue of tolerability of the patient, somebody who is drug naive, never had anti-epileptic drugs, frequent seizures, and you bring the patient and you tell them parents or the caregiver, I will start this patient, for example, on valproate and lamotrigine, or valproate and clonazepam, etc. I think that we should try one medication, and probably we can early introduce second medication. In general, I don't like choosing two medications together from the first, maybe one after the other in this particular condition like Lennox-Gastaut.
Very clear, thank you. How do you evaluate the cognitive decline? That's the question, to evaluate the cognitive decline in polymedicated patients.
Well, first of all, when the patient comes in their follow-up, let's go with a simple clinical tasks. Then when you start the medication, patient comes in your clinic and the patient will tell you, I'm becoming slow, more sleepy, loss of concentration, poor performance if they're students or work. That's on clinical aspect. And of course, the other issue is the neuropsychology. Because neuropsychology is an integral part of the evaluation of epileptic patients, whether they're pharmacoresistant.
Thank you very much, Dr. Sonia, for this nice lecture and nice answers. Thank you very much. And may I give the mic to Professor Mr. Awa, if he is present? Is he available to introduce?
Yes, we are.
Hi.
How are you?
Thank you very much.
Good. Thank you, Sonia Khan, for this excellent talk and the comment which followed. It's very, very nice. Thank you.
Nice to see you. Thank you.
So, should I go and introduce Professor Naim Haddad?
Yes, thank you.
Can I do it? We are online now?
Yes, we're online.
Okay. So, after a very nice talk, I am sure that the second talk by Professor Naim Haddad will be as good as that one. So, I have a great pleasure to introduce my friend and colleague, Professor Naim Haddad, who is a professor of clinical neurology at Well Cornell Medical College in Qatar, and he is also a consultant neurologist at our institution, Hamad Medical Corporation. Dr. Naim Haddad runs his epilepsy practice at Hamad Medical Corporation and is actively engaged in all aspects of neuroscience teaching at Well Cornell Medical College, Qatar. He is the recipient of multiple teaching awards. Dr. Haddad research interest focus on clinical neurophysiology, epilepsy, and magnetoencephalography. He is the recipient of many research grants and authored more than 50 manuscripts, book chapters, and abstracts in the field of epilepsy. Dr. Haddad is a member of the American Academy of Neurology, the American Epilepsy Society, and the American Clinical Neurophysiology Society. So let's listen to the talk of Professor Naim Haddad regarding evaluation and management of first unprovoked seizure. Thank you, Professor Haddad. Go ahead.
Thank you, Professor Misrawa, for this nice introduction. For the next 30 minutes or so, I'll try to give you a brief overview on the management of the first seizure. This scenario is a pretty common one we encounter both in consultations in the emergency room and in our offices. 150,000 adults present annually with an unprovoked first seizure in the United States. So it's again a pretty common scenario. And one of the main tasks that we neurologists are responsible for is to counsel these patients about the risk of seizure recurrence. Some of these patients who present with a first seizure may go on to develop more seizures in the future, but some will never have another recurrence. So it's our role to try and quantify as much as possible the risk of seizure recurrence and counsel the patient accordingly. And over the next 10-15 minutes or so, I'll try to share with you how to do so. So first, when we encounter a consultation about a possible first seizure, you know, we really have to go over like a list of questions or tasks to go over. You know, first thing we need to do is to confirm that what we're dealing with is indeed an epileptic seizure and not an imitator, not a seizure mimicker. There are many paroxysmal events that may mimic seizures, and they really need to be ruled out and separated because their management is completely different. This is an incomplete list of paroxysmal events that may mimic seizures. You know, maybe the two big mimickers for seizures are syncope and psychogenic non-epileptic events. Almost 20% of patients referred to neurologists for the evaluation of a first seizure turn out to have you know, something else, you know, a different event that is not epileptic. So again, that's why, you know, ruling out other seizure mimickers is important at the first encounter. So I'm not going to go into the details of how to differentiate all these seizure mimickers from seizures themselves, but to briefly say that syncope, you know, typically starts with a lightheaded feeling, basically dimming of vision, a sensation of warmth or diaphoresis before the loss of consciousness. Usually the recovery quick in syncope, you know, whereas with seizures, you have like some time of post-ictal confusion. Tongue biting is more common in seizures, of course, compared to syncope, especially lateral tongue biting, and so on and so forth. Again, this is a non-exhaustive list of the differential diagnosis of a first seizures. You know, I put here transient ischemic attacks, paroxysmal movement disorders, parasomnias. You know, they need to be differentiated from seizures occurring during sleep, psychogenic events, and I can go on to include migraine, transient global amnesia, you know, medication side effects, intoxications, and so on and so forth. So again, first question to try and address when we are evaluating a consultation for a first seizure is to rule out mimickers of seizures. The second question that we need to address once we're convinced that we're most likely dealing with an actual seizure is decide whether this is really the first seizure, because patients typically come to the emergency room for like their major events, you know, typically like the generalized tonic-clonic seizures. And they may say that, oh, this is the first time this has happened to me. I've never had something like that before. But, you know, on further scrutiny, you may find out that they have had other seizure types in the past, but these seizure types are mild and they never basically required the patient to seek medical attention. So it's very important to carefully question the patient and basically the family members about some other subtle seizure types that may have occurred in the past, like myoclonus, absence seizures, focal seizures with impaired awareness or without impaired awareness. Question the patient and also, you know, his or her caregivers about possible nocturnal episodes that escaped medical attention. So it's very important to remember that not every patient who presents with what looks like a first seizure has indeed a first epileptic event. Many of these patients, with further scrutiny of their history, you know, you will find out that they have had basically milder seizure types in the past, and thus, you know, they qualify for the diagnosis of epilepsy, as you have evidence of recurring unprovoked seizures, and the management will be completely different than an actual real first seizure. You know, a third question that needs to be addressed in the first seizure scenario is to decide whether the seizure is provoked by an acute central nervous system illness or an acute systemic illness or an acute metabolic or electrolytic disturbance or a drug intoxication or a drug withdrawal, and so on and so forth. From, you know, differentiate these provoked or acute symptomatic seizures from the unprovoked seizures. The unprovoked seizures basically occur without a clear CNS pathology, or if there is CNS pathology, central nervous system pathology, that pathology is old or chronic. So it's very important to differentiate provoked seizures from unprovoked seizures, because the prognosis is different and the management is different. You know, if you're dealing with a provoked seizure due to an acute metabolic disturbance, you really need to correct that metabolic or electrolytic disturbance. If you're dealing with a seizure in the context of an acute encephalitis or stroke, again, the management is different compared to a seizure that occurred on a brain that looks structurally normal, or you know, whether the seizure has occurred on a chronic or old central nervous system insult. So this differentiation is very important. So again, I will basically go over again these three questions. You're called for a consultation for a first seizure. Make sure that you quiz the patient and the witnesses about who have seen the event, about the characteristics of that event, so you can decide if it's an actual seizure or something else. Quiz the patient and the family members about possible mild seizure types that have occurred in the past, and then also, you know, look for acute central nervous system pathology or acute systemic insults or drug intoxications and so on and so forth, to see if there is an acute provocative agent that can explain the seizure. Again, this is like a list of possible causes for acute symptomatic seizures or provoked seizures. Some, some may consist of acute CNS insults, like within 1 week of a stroke, within 1 week of a traumatic brain injury. Basically, also, the seizure is provoked if it occurs in the context of alcohol withdrawal. Also, if the seizure occurs, in the context of an acute metabolic or electrolytic disturbance. The differentiation between, acute symptomatic and remote symptomatic seizures is very important because they behave differently. Their management is different, their prognosis is different. And this is a study basically published in Epilepsy like more than 10 years ago. And the authors of this study looked at acute symptomatic seizures following an acute traumatic brain injury and acute sorry, I'm hearing some noise in the background. Please mute your microphones. Keep your microphones muted. Again, the authors of this study looked at patients who suffered a first acute symptomatic seizure in the context of an acute traumatic brain injury, acute stroke, or acute central nervous system infection versus patients who had seizures remotely from such incidents, like, after a stroke, but 1 year later, or, 1 year after a CNS infection, or 6 months after a head injury, and so on and so forth. And what they found that the patients who had acute symptomatic seizures were 9 times more likely to die within 30 days of the seizure compared to the unprovoked remote symptomatic seizure. But on the other hand, the risk of seizure recurrence on the long run was lower for the acute symptomatic seizures compared to the unprovoked remote symptomatic ones. The acute symptomatic seizures were 80% less likely to experience a subsequent unprovoked seizure over, over 10 years. So the prognosis of acute symptomatic seizures is different than the prognosis of unprovoked, even remote symptomatic seizures. The risk of seizure recurrence is different, and the risk of acute mortality is different. Okay, now, after establishing that the seizure is indeed epileptic, not a mimicker, and that this is the first unprovoked seizure, and that there are no acute provocative etiologies, now, the role of the neurologist is to tell the patient what is the risk of future seizures. And, the risk varies, really. It's not homogeneous. It's not a homogeneous single number. And if you look at the literature, the reported risk for seizure recurrence after a first unprovoked seizure may vary from the low 20s to more than 70%. But roughly, the average or the median risk of seizure recurrence or rate of seizure recurrence within 2 years after the index first seizure, it's around 38%. And this is a pooled average from patients who received treatment after their first seizures and patients who did not. So these are like population-based studies who followed patients after a first seizure over many years. Some of these first seizure patients received anti-epileptic medications, some didn't. So you have to take this rate with a grain of salt. But the 2 most consistent predictors of recurrence are the following 2 factors. Having an abnormal EEG, especially with epileptiform discharges. that's a more robust prognostic factor for recurrence than the rather non-specific slowing on or background asymmetry, and whether there is an underlying remote etiology to the seizures, you know. So patients who have a single unprovoked seizure, but they have a normal EEG and a normal brain MRI and no underlying etiology to explain the seizure, they are at low risk for seizure recurrence. But patients who have epileptiform discharges on the EEG and or who have a clear underlying etiology that you detected either by history or by imaging the brain, these patients are at higher risk for seizure recurrence and may need subsequently to be counseled about the intake of anti-seizure medications, you know, even after a single seizure. Again, this is a table summarizing the predictors, the positive predictors for seizure recurrence after a first unprovoked seizure: prior brain injury, abnormal epileptiform EEG, the presence of epileptogenic lesions on brain imaging. They double to triple the risk of seizure recurrence, you know, if they are present. Also, the occurrence of the seizure, of the first seizure during sleep, apparently has a higher risk for seizure recurrence compared to a seizure that occurred during wakefulness. Some factors that were looked at and were found to have no influence or minimal influence on the risk of recurrence are the following. Age is not a factor when you're trying to quantify the risk of recurrence. So whether the patient is a child or an adult, that doesn't influence the risk of seizure recurrence. The presence of family history of seizures, there is conflicting data in the literature on this, but apparently whether there is family history or no for seizures, it is not a robust, at least not a robust factor in the risk of seizure recurrence. The seizure type, whether it's like a focal or generalized, also that is not like a significant variable to determine the risk of seizure recurrence. And the first seizure may be, you know, a brief 1 minute, 30 seconds event, but it could be also status, a very prolonged event. Whether the first seizure is a brief seizure or fulfills the timeline criteria for status epilepticus, that does not influence the risk for seizure recurrence. Also, you know, some patients may present with, for the first time, with a cluster of seizures. So more than one seizure within 24 hours. And such a cluster of seizures, prognosis-wise, will behave the same as the event had been a single seizure when it comes to the risk of seizure recurrence in the future. So this is a list of factors that do not seem to influence the chance of seizure recurrence after a first unprovoked seizure. Now, if there will be seizure recurrence, when do these seizures occur? When does the second seizure happen in the patients who are gonna recur? Now, most patients who are gonna have a seizure recurrence will have it soon after basically the first seizure. Soon meaning, you know, within weeks, months, and maybe in the first 1 to 2 years. So the highest risk is in the first year or two, the first few months to 1 to 2 years following the first seizure. The risk basically, you know, continues to you know, there is still risk even years down the road, but the curve is less acute. You know, if you go beyond 1 to 2 years after a first seizure without any seizure recurrence, you know, your risk for having another seizure 3 years, 5 years, 10 years down the road is above the normal population, but it's not very high, not as high as, you know, the first few months following that first seizure. Now, you know, having said that, now in order to answer all the questions we just raised, is this an actual seizure? Is this the first? Is it provoked or unprovoked? And what is the risk for seizure recurrence? You know, you really need to run a battery of tests to evaluate all these questions. Of course, first of all, very important, you need to take a detailed history, a detailed description of the event, a detailed physical exam. That's very helpful. You typically need to run some blood tests, to rule out electrolyte metabolic disturbances. They are very helpful in some scenarios. If you're suspecting acute CNS infections like meningitis or encephalitis, you may need to do a lumbar puncture. In some communities, where drug abuse is prevalent, you may need to run a urine drug screening, since many illicit drugs can trigger seizures. And ultimately, you also need to get some brain imaging, CT or brain MRI, and most likely you're gonna need to obtain an EEG. And I'll elaborate on the roles of these on neuroimaging and EEG in the workup of the first seizure. So we typically always need to image our patients presenting with the first seizure. Most of the time in the emergency room, they will have a CT scan done, but MRIs are more reliable. They are more sensitive at detecting subtle pathologies. In the context of a first seizure, the MRI of the head is positive in almost a quarter of the patients, meaning it shows an epileptogenic pathology. The most common pathology encountered, on the imaging of the first seizure is gliosis or encephalomalacia, typically due to either an old head trauma or an old stroke, and so on and so forth. This is, the imaging studies from the seen in European and North American literature. However, basically, you need to keep in mind that if you look at imaging series for first seizures in the emergency room from developing countries, you may find a different set of pathologies on imaging. For example, this is a series from Qatar. CT abnormalities in patients who presented with a first seizure to the emergency room. And in Qatar, we have a large immigrant population from Southeast Asia. And many of our patients who visit to the emergency room, are ethnically, or they are immigrants from Southeast Asia. And, this makes neurocysticercosis and calcified lesions related to remote neurocysticercosis infections as the most commonly encountered basically pathology on brain imaging, rather than simple gliosis and encephalomalacia like it's noted in Western literature. So keep in mind that the different etiologies and their distribution and proportions may vary depending on the country you're dealing with. So you may see more infections and diagnose more infections like neurocysticercosis on imaging, after a first seizure in some developing countries, which is, this disease is almost non-existent or has a very low prevalence in European and North American countries. Okay, now, besides imaging, you typically need to do an EEG. As I mentioned earlier, the presence of epileptiform discharges predicts a higher risk for seizure recurrence. So if you have a first seizure and the patient's exam is normal and the brain imaging is normal, your EEG is now, the most important prognosticator. It will play a decisive role. The findings on the EEG will play a decisive role in estimating the risk of seizure recurrence if the patient's exam and the neuroimaging are normal. However, there are some problems with the EEGs. What kind of EEGs do we get? Do we get like routine 20, 30 minutes EEGs? Do we get long studies, 24-hour recordings, 6-hour recordings? Do we get repeated studies? You know, when to get the EEG, like in the emergency room or a few days later? There are some questions that are not resolved yet regarding the optimal use of EEG in the workup of a first seizure. Now, the existing literature tells us that a single EEG has probably, you know, a yield of, for showing epileptiform discharges somewhere between 20 to 40%, a single EEG following a first seizure. Now, if you do repeated EEGs, you may increase that yield to over 60%. So, you know, this raises a question that, you know, a single standard EEG may not be enough to tell you that there are no epileptiform discharges and to, you know, allow you to reassure the patient that he or she falls in the low risk group for seizure recurrence. So again, you know, there is some literature that suggests, you know, that the EEG has a higher yield if it is done, you know, close to the seizure time-wise in the context of a first seizure, you know, and the further you go time-wise from that index event, you know, the less likely you're gonna pick up abnormalities on the EEG. So the yield, the sensitivity of the EEG is higher, closer to the seizures. That's why some groups are advocating to do the EEG, preferably in the emergency room before you discharge the patient. And if you cannot do that in the emergency room, maybe try to obtain the EEG at least in the first 24 to 48 hours. The second question is for how long to record, you know, do we do like a 20-30 minute recording? Do we do a 1 hour recording? Do we record for many hours? Do we keep the patient and record him or her overnight? There are no clear guidelines for that. Now, I'll share with you some information we've learned from our experience. So in the last few years, we have been obtaining 24-hour EEGs on some patients who are presenting for a first seizure. Many of these patients would typically have a routine EEG that is normal, but then the neurologist is not satisfied with the duration of the EEG. So the neurologist would request a 24-hour EEG recording, mainly to record like the EEG overnight, get more sleep, recording, you know, hopefully with a higher yield. So we looked at our experience, you know, with this approach, and we found 25 patients who are like teenagers or adults who have undergone 24-hour video EEG recordings following a first unprovoked seizure. And here are some of the results we found, you know, out of these 25 patients, and bear in mind that like most of them had normal routine EEGs already. So the video EEG is their second study. More than 60-70% of them had normal routine EEGs. So in these patients on the 24-hour EEG recording, on these 24-hour video EEG recording, 11 of these 25 patients, that's 44%, showed epileptiform discharges. 10 had focal discharges, only 1 had generalized spike and wave. Basically, 8 of these 11 patients who had epileptiform discharges showed these epileptiform discharges late during the recording, you know, beyond 1 hour of recording. When we're running our 24-hour EEG, we run the first hour as a standard EEG. So we basically record some wakefulness with eyes open and closed, then basically do photic stimulation and hyperventilation, and then we ask the patient to try and take a nap. So we run the first 1 hour of our 24-hour EEG recording like with a standard EEG protocol, you know. So we try to obtain sleep and run the hyperventilation and the photic stimulation early on. But still, despite that, 8 of the 11 patients who showed epileptiform discharges only exhibited these discharges beyond the 1 hour limit. So had these patients been having just a standard 30-45 minutes EEG, these epileptiform discharges would have been missed. Surprisingly, in 4 of these 25 patients, we recorded subtle seizures, even though these patients are coming with a single event, single seizure. You know, the 24-hour recording captured, you know, subtle epileptic events, basically, you know, typically with the patient not being aware that they had a seizure during the recording. Let me go into more details about the results of this study. So we found a median latency to detecting epileptiform discharges of 170 minutes. That's 3 hours. That's 3 hours. Again, that's beyond the typical time duration of a standard EEG. We finally concluded that, you know, for each 3 patients who had undergone this 24-hour EEG recording after a first unprovoked seizure, we found epileptiform discharges in 1 patient who would have been missed had we just limited our EEG studies to just routine 30 minutes, 40 minutes, 1 hour EEGs. So we conclude that in the evaluation of a first seizure, the capture of epileptiform discharges is increased with 24-hour EEG recordings. This most likely stems from a combination of increased sampling and more robust sleep recording. We even, like I mentioned, to our surprise, you know, we recorded subtle seizures in some patients, and I'll share with you some of these cases. Again, all of these patients were recorded for 24 hours after a single seizure, and they denied having any kind of seizures in the past. They were very, you know, scrutinized about that. So this is a patient who during the recording had a subtle seizure out of sleep. And you can see here, there is this left temporal evolving discharge. This is only part of the seizure. Clinically, the patient was asleep and briefly opened his eyes, fidgets, moved in the bed, and that's it. You know, when the patient was awakened and asked, you know, he was completely unaware that he had anything. This is another patient, you know, who had a brief seizure during wakefulness and still was unaware that he had anything, basically. So you could see here, like the sudden appearance of EMG artifacts over the left temporal leads. And there is an underlying brief left temporal discharge followed by left temporal slowing. The patient basically exhibited repetitive grimacing and manual automatisms, very subtle, and then again did not remember that he had anything. This same patient showed also interictal sharp waves, again in a left temporal distribution. So this is just a sample of, you know, surprisingly patients who, you know, on whom we recorded seizures while we were investigating them for a first unprovoked seizure. So a word of caution here, single standard EEGs apparently have a relatively low sensitivity at detecting the interictal epileptiform discharges after a first unprovoked seizure. So having normal routine EEGs after a first unprovoked seizure, that may be insufficient to reassure the patient that he or she is in the low risk for seizure recurrence. So we probably need to either obtain repeated EEGs, and this has been done in some centers and has been reported in the literature, or maybe go to a you know, one long study, like probably 24 hours, to maximize your yield for detecting epileptiform discharges. You know, because once you detect these epileptiform discharges, you can counsel the patient more appropriately about the risk of seizure recurrence and whether they need to go on anti-seizure medications or no. It's of very important practical consequence. Now we're done with the workup. So we've examined the patient, you know, done the workup. Now, you know, we're gonna tell the patient, go on anti-seizure medication. No, wait, don't go on anti-seizure medication. So the decision to treat with an anti-seizure medication is not automatic and is rather complex. And the decision is based on the likelihood of recurrence. And I already discussed with you factors that can increase the risk for seizure recurrence, and also discuss with the patient his or her individual preferences and considerations. So many factors should be considered when we're deciding with the patient whether to start on an anti-seizure medication or no. Like treatment, most physicians, because of the high risk for seizure recurrence, they encourage treatment, if the EEG shows epileptiform discharges, or if there is a clear underlying pathology in the brain, whether detected either by history or by brain imaging. But even in the presence of many risk factors for recurrence, treatment may be deferred if that's what the patient wants. We can only counsel, our patients about the risks and then guide them and include them, in the treatment decision. Besides, the risk for seizure recurrence, there are other factors that need to be considered, for starting medications. Is the patient driving or not? What are the job requirements for the patient? What is the patient's likelihood to adhering to a medication if we prescribe it? And so on and so forth. So really the patient's opinion is crucial here when we are trying to decide on treatment, whether to treat or no. Now, briefly, if you decide to go on with immediate treatment after a first seizure, there are studies that looked at the efficacy of such treatment. Immediate treatment after a first seizure clearly reduces the risk of a second seizure. But deferring the treatment to after a second seizure does not jeopardize the long-term remission, the long-term prognosis. So even though immediate anti-seizure medications reduce the absolute risk for seizure recurrence within 2 years by 35% compared to no immediate treatment, immediate treatment as compared with delayed treatment until a second seizure does not change the rate of seizure remission over the long term. So whether you treat after a first seizure or whether you wait for a second seizure to start the anti-seizure medication, the long-term outcome for seizure remission is the same, basically. Okay, now what happens after a second seizure? This is just one slide on this. After a second seizure, the risk of seizure recurrence is clearly above 70%. 70 to 80% in the next few months. So the risk of seizure recurrence is high. The EEG has no predictive value after a second seizure on whether there will be more recurrence or not. So most of the time, we recommend treatment after a second seizure, except under specific circumstances, like in some maybe benign childhood epilepsy syndromes and some specific scenarios. This is the last slide. I will close with it. This is a summary slide from Wiley's Treatment of Epilepsy book. So basically, once you're encountering a patient with a first seizure, you need a careful history, physical exam, and workup to decide whether this is an epileptic event or no. If it's not an epileptic seizure, basically treat accordingly depending on your diagnosis about the nature of the event. If this is indeed an epileptic event, decide whether it's provoked by an acute medical or neurological illness versus being unprovoked, and also decide if this is really the first event, or have there been like milder seizure types in the past. If there are no acute provocative, etiologies, and you're sure that this is the first seizure, then you're gonna rely on your imaging and your EEG to quantify the risk for seizure recurrence. Basically, again, bear in mind, a standard EEG may have low sensitivity, and we may be missing patients with epileptiform discharges and high risk for seizure recurrence with a short EEG. So keep your mind open for the possibility of either obtaining repeated EEGs, or if you have the capability, do a 24-hour EEG recording. And depending on the results, basically counsel the patient about the need to start anti-seizure medications or not. I will stop here, so I don't want to go further over time. You know, I'll stop here and take any questions if time allows.
Thank you very much, Professor Naim, for this excellent talk. Really excellent and clear. So there are there are 8 questions here. 8 questions. I will start with the first one. Okay. Is an epileptic patient, does the epileptic patients work at night shift?
Okay, now, you know, sleep deprivation can trigger seizures. So you really need to counsel your patients about that. And some patients, you know, may need to avoid the night shifts basically in order to not jeopardizing their sleep regularity. So I've had situations where I wrote letters to employers, you know, asking them to basically allow a patient to work a regular shift, not a night shift, or change from night to day, and so on and so forth, because sleep deprivation can be a seizure trigger. So we need to be mindful of that. And sometimes we may need, you know, to write letters on behalf of our patients to minimize their sleep disturbance or disruption, basically, to avoid seizures as much as possible.
Okay. Thank you. The second question is, do you start a patient with recent ischemic stroke without seizure on anti-seizure medication?
No, you know, we do not use anti-seizure medications for seizure prophylaxis in strokes. So we only treat the patients if they have seizures. So, but random stroke patients who present without seizures, we don't usually, there is no role for giving them anti-seizure medications to prevent the seizures. It doesn't help, they will get side effects, and you know, it will complicate their prognosis.
The third question is, what is the percentage of risk of recurrence of a seizure in patient with the first unprovoked seizure with a current or past meningitis with a normal EEG? A patient has a meningitis, he had no seizure, and he has a normal EEG. What is the risk of recurrence?
Okay, now the risk of recurrence depends on basically whether the seizure occurred acutely during the acute meningitis episode or remotely from it. You know, if the seizure occurred during the acute phase of the infection, the risk of recurrence on the long run is low. It's low. But if the seizure occurred, like, you know, months after the healing of the infection, or years after the healing of the infection, the risk is high, you know, probably more than 60, 70%.
The question is, do you prescribe anti-epileptic treatment after first seizure, or does your decision depend on change on the EEG?
You know, the decision is not based on one single factor, but the EEG is one of the factors and one of the variables you need to take into account when you're counseling the patient about starting medication or no. If there are clear epileptiform discharges on the EEG, I would tend to tell the patient that he or she is at high risk for having another seizure in the near future, and you know, try to start a medication. But again, if the patients refuse and would prefer to wait, we do that sometimes. You know, some of them never have a second seizure, even if they have multiple risk factors for seizure recurrence.
Do you, what you said in your presentation, apply also to children?
In general, yes. In general, with few exceptions, most of what I mentioned applies to children. But in children, you may be able to accept a second seizure you know, more often than in adults. You know, children don't drive. They are like more often in a supervised environment. So waiting for a second seizure before you start treatment is less risky in children compared to adults. Adults have to drive, they have jobs, they operate heavy machinery, they, you know, do risky activities. So in children, you can be a little bit more conservative in starting treatment and wait a little bit longer, but the general scheme still applies.
Okay. Another interesting question: how can you cancel a patient with the first seizure regarding driving, about driving?
I typically tell them to, you know, again, as I mentioned, the risk of the second seizure is highest in the first few months after the first seizure. So I still tell them, you know, to not drive for at least few months after a first event. Now, if they go on for many months, they don't have any seizures, then the residual risk is lower, and you know they are allowed, you know, like to resume like their normal activities, including driving.
Okay.
But remember, you know, the highest risk is like in the first few months. That's where the peak is highest for the second seizure. As time goes on and you have more time from the index seizure without any recurrence, the patient can slowly start relaxing his or her, you know, precautions and limitations.
Okay. After a first unprovoked seizure, do we do any neuroimaging?
Yes, we always need to do neuroimaging. We always need to do neuroimaging. You know, this is a consistent and constant part in the workup of a first seizure. Obtain neuroimaging, preferably MRI if you can.
Are you with the prophylactic 1 to 2 weeks after neurosurgical operation? Any
Yes.
neurosurgical operation?
Yes, for a few weeks, for a short period after a craniotomy, it's reasonable to give an anti-seizure medications, but don't give long-term treatment if there are no, you know, okay, just for a few weeks.
Okay, after acute symptomatic stroke and seizure, what kind of anti-seizure medication would you recommend? Which one? Which anti-seizure medication for focal stroke?
Yeah, for acute symptomatic seizures now, you know, sometimes you treat for a short period, you know, like levetiracetam is a common drug we use in acute situations. It exists in IV formulation. It has not much drug-drug interactions, you know, when a patient is taking a lot of other medications. So there is no single choice basically, but levetiracetam is a common drug we use in acute scenarios. And you don't have to treat every acute symptomatic seizure. If the underlying etiology can be corrected quickly, you probably don't need to give the patient an anti-seizure medication, you know, but sometimes you need to treat for a short period.
Okay, an interesting question. What would you suggest to a pregnant patient with the first unprovoked tonic-clonic seizure with a normal EEG and normal MRI? I was wondering if, due to the fact that she is pregnant and the risk of this seizure for the baby, we should be more prone to treating them.
Well, you know, I mean, there is no right or wrong answer here. You know, yes, you give treatment, you will decrease the risk for an immediate seizure as the patient is continuing to take the treatment, but you may be also exposing the fetus to the side effects of the anti-seizure medications, you know, and the patient may experience side effects herself. So, so still, if the MRI is normal, the EEG is normal, the neuro exam is normal, you know, this patient, the risk for another seizure is probably in the low 20s, % over the next month to a year or so. So it's not a bad idea to wait and see, you know, because then, you know, pregnant women, you're starting an anti-seizure medication, especially in the first part of the pregnancy, you may be running the risks of teratogenic side effects.
Okay. How long should we treat seizure provoked by cerebral venous thrombosis?
Okay, now again, if you know, we treat acutely, we don't treat for too long. There are no clear guidelines, but you know, typically we treat them for weeks to months. If there is no recurrence, you know, the EEG doesn't show any clear epileptiform disturbances, you can take them off. Again, if the seizure occurred in the acute phase of the infarct, of the venous infarct, the long-term risk for seizure recurrence is not zero, but it's not as high compared to the seizure occurring 1 year, 6 months after the stroke. So if the seizure occurred on a chronic or old CNS insult, the likelihood of it recurring is high. If the seizure occurred during the acute phase of the pathology, the risk of recurrence is there, but it's not that high and probably does not warrant, you know, treatment for years.
I don't have any. The other questions are the same regarding stroke, and so I don't have other question. Yeah, I don't have.
Okay.
Yeah, there is one last question. You know the net facility difficulty in Iraq. My email is. Thanks. Can please second record. No.
Dr. Bulnor, we don't have time for any more questions on this presentation. I'm afraid we will have to move on to the next presentation. Thank you.
Thank you.
Thank you.
Thank you.
So now we will move to the last but not the least section of this very good presentation. Could you allow the video to open? I cannot open the video. If you can. Okay, thank you very much. So I'm delighted to present my colleague, Dr. Haifa Al-Arabi. She is graduated from College of Medicine and Health Center from Sultan Qaboos University at Oman. Then has completed neuro residency and fellowship of pediatric, adult epilepsy and neurophysiology at Cleveland, US. She's now a consultant of neurology at Sultan Qaboos University Hospital, and she's running the EMU unit. She's highly involved in the educational curriculum for the College of Medicine and their examination committee. We are very welcome, Dr. Haifa, and we will listen for your presentation. Thank you very much.
Thank you, Dr. Reem. Thank you for the organizers. As you can see today, that we have moved from the most complex discussions of epilepsy, and that's medical resistance epilepsy, to the most basic one that I will be presenting today, and that's epileptiform phenomena. Mosby has said that in 1971 that every spiky looking wave is an artifact unless there are one or more good reasons for suspecting otherwise. So what is an epileptiform phenomena? They are interictal epileptiform discharges that are a product of summation of excitatory postsynaptic potentials and inhibitory postsynaptic potentials. But we also learned from the penicillin-induced epilepsy model that they are most likely paroxysmal depolarizing shift rather than the postsynaptic potentials. Most of the time, the polarity of the interictal epileptiform discharges are negative, but we will talk relatively later that it can be also the opposite. The interictal epileptiform discharges are considered to be a biomarker of epilepsy. So if we would like to define it, how would we say? The Glossary of EEG terms in 1974 defined the epileptiform activity as distinct waves or complexes including spikes and sharp waves that are distinct from the background activity, definitely. And they also resembled records of patients who were suffering from epileptic disorders. Other definitions are abnormal discharges that occur between seizures, so those are the interictal discharges, or paroxysmal bursts of slow waves that actually, if they are present, they indicate low seizure thresholds, as we see in aorta in childhood absence or TERDA in temporal lobe epilepsy. Epileptiform discharges in general has been classified as generalized, focal, or benign epileptiform variants. In this presentation, I'll be touching basically on generalized and focal. I'm not presenting the benign epileptiform variants. So to start with the simplest, spikes and sharp waves. They are sharply contoured waveforms that are distinct from the EEG background as we said in the definition, and usually they have negative polarity. Their duration may vary from less than 70 milliseconds in spikes to more than 70 milliseconds in sharp waves. The main feature of those waves that they stand out from the background, that you can really say that they are not part of the rhythm. They're usually followed by a slow wave. They're usually of negative polarity, but they can be also positive. The slopes are asymmetric, and the initial negative deflection is usually the steepest, and they have a field that extends over a few seconds. In this presentation that I shared from our EEG lab, this is a spike wave. Some people would say that it's like a needle that you cannot sit on to differentiate it from a sharp wave. This is an example of a 21-year-old and came with seizures, and her EEG shows left hemispheric spikes. But here you have a sharp wave. Spikes are thought to be generated by synchronous depolarization of thousands of neurons over an area of 6 centimeters square, while sharp waves are thought to be a result of a pool of neurons further from the recording electrode. That's why they usually look blunter compared to a spike. And here we have left temporal sharp waves in a 22-year-old lady who presented with non-lesional temporal lobe epilepsy. And you can see if you compare this one with the previous one, these look more blunter compared to the spike that looks almost like a needle. Now, spike and slow wave complex is a spike or a sharp wave followed immediately by a slow wave that can be of variant frequencies and amplitude. Usually those discharges are generalized, but you can see them with shifting emphasis or shifting maximum, where is it maximum, from time to time. The underlying background is usually abnormal, either generalized or focal. And the following slow wave in these discharges can represent inhibition of the subsequent hyperpolarization of the cortical neurons that follow the initial depolarization. This is an example of a spike and is followed by a slow wave in a lady who presented with dialeptic seizures. Polyspikes, on the other side, are discharges that are multiple spikes observed in rapid succession at a frequency of 10 Hertz or further. And they can be followed also by a slow wave. You can find fragmentation of those polyspikes that may override the slow wave component from time to time. And they are mainly seen in generalized epilepsy, mainly with myoclonic seizures. And actually, when you record them as a routine EEG in your EEG lab, sometimes these are associated with a myoclonic jerk. This is an example of a polyspike in a lady who had myasthenia gravis and presented with seizures. And her semiology was simple partial seizures. And I'll show you another example of polyspikes. You can see here that they're overriding each other and then followed by a slow wave. In this example, for example, you can see the polyspikes very clear, followed also by a slow wave. And this is surprisingly the 37-year-old lady who has generalized epilepsy, but a focal semiology, where her seizures start as left versive, followed by left hemibody clonic, then bilateral tonic-clonic seizures. And actually all her interictal activity is of generalized origin, and also her seizure onset is generalized. We could not assess any focal onset of her EEG during a seizure. If we take further on 3 Hertz spike and slow wave, the typical EEG pattern is usually seen in absence epilepsy. It's bisynchronous, stereotyped, symmetric spike and slow wave that occurs at 3 Hertz. These discharges are usually maximum in the frontal regions. And the discharges, if they are prolonged more than 3 seconds, they can actually be associated with clinical symptoms like arrestive activity, blinking of the eyes, altered consciousness, and staring. They are usually induced in our clinic, for example, or in the EEG lab by hyperventilation. Hypoglycemia can induce it, but usually when you alert the patient, those discharge attenuate, and also during sleep. This is a nice example of a 3 Hertz spike and wave for a 16-year-old girl who presented for evaluation of staring events during school and was found to have absence epilepsy. If we move now to the generalized epileptiform discharges in general, in adults, usually they are of bifrontal predominance, and they can be sharp or spike waves. And actually they are frontally observed mainly, where sometimes you do not see them in the posterior head regions. And actually I was surprised to see some of the neurologists, they would comment on the EEG as bifrontal epileptiform discharges, where actually they are generalized epileptiform discharges with the maximum frontal origin that sometimes would disappear in the posterior head regions. The generalized spikes are typically suggestive of generalized epilepsy, and they can happen in partial epilepsy, where it starts focally, but it rapidly spreads to the other hemisphere. And this is called secondary bilateral synchrony that we will talk about it later in the presentation. In most of the time, the generalized epileptiform discharges can happen at certain frequencies, and this can help us to characterize or define a few syndromes. For example, if it happens 3 times per second, as I explained earlier, it's childhood absence epilepsy. 4 to 6 Hertz per second, per second, it's juvenile myoclonic epilepsy. And if it is slower than that, that can be seen in the Lennox-Gastaut syndrome. What about generalized paroxysmal fast activity? These consist of runs of spikes or sharp waves that occur in a beta frequency range, and they usually appear during sleep and maximum in the frontal or the fronto-central regions. Usually they are very short, between 2 to 4 seconds, but they have been observed as long as 18 seconds. They are commonly seen in patients with epileptic encephalopathy and intellectual disability, but it has been seen also in people with normal intelligence. And it's mainly associated with generalized tonic-clonic seizures or absence seizures. This is an example of paroxysmal fast activity that you can see in a patient who came with previous frontal lobe epilepsy post-surgery due to a pathology of focal cortical dysplasia, but then he came after surgery with recurrent seizures. And you can see here's the paroxysmal fast activity at 30 millimeter per second. Sometimes you cannot see them clearly, so then you change the page, and at 55 millimeter per second, you can see it very clearly, these beta frequency range paroxysmal fast activity. HIPS arrhythmias are high voltage rhythmic pattern consisted of multiple spikes and slow waves that occur almost continuously throughout the recording. It is very commonly seen in patients with infantile spasms or myoclonic jerks. And the EEG component of infantile spasm consists of those high voltage spike or sharp waves followed by an abrupt electrodecrement in the EEG tracing. Usually such patients have a poor prognosis, and usually they are of low intelligence with mental retardation and recurrent seizures. This is an example of an 8-month-old girl who presented with recurrent tonic movements. And if you can look at this EEG, it looks very chaotic, that if you, as some of us when during residency or fellowship, we were taught that if you flip this EEG, it would all actually what I see also. Moving from the generalized epileptiform discharges to focal epileptiform activity, focal epileptiform discharges are usually intermittent, but if they repeat, they are irregular in comparison to the generalized epileptiform discharges. The location remains usually fixed in adults compared to children. But you can find mirror focus, like you can see it on one hemisphere and it would show mirror focus in the other hemisphere. And that's because of one of them would trigger the other one. The most common one is temporal epileptiform discharges, and this is because the temporal lobe constitutes a very big portion of the cerebral hemisphere. And on top of that, it has one of the highest epileptogenic areas, and that's the hippocampus. These activities usually are activated during sleep and during drowsiness. And for example, the interictal epileptiform discharges, known as the frontotemporal, usually originate from the mesial temporal lobe, while the ones from the mid-temporal region or the posterior temporal spikes originate from the neurocortical generators. Patients who have unilateral temporal lobe epileptiform discharges, actually on the EEG, they can have bilateral temporal epileptiform discharges. And this is because of the connectivity between the temporal lobes. Usually people with temporal lobe epileptiform discharges can have slower activity that represents surface reflection of the underlying pathology. And these are known as temporal intermittent rhythmic delta activity, TIRDA. And you should have very low suspicion that these people have epilepsy, even if you did not see their epileptiform discharges, and you should follow them with recurrent EEGs. This is an example of a 36-year-old woman with medical refractory bitemporal lobe epilepsy. And you can notice here that the left temporal chain shows recurrent epileptiform discharges. And on the other side, there is independent right temporal lobe epileptiform discharges. And her semiology, she has psychic aura that goes into right aversive and then complex motor seizures. This is the same patient during sleep. And we said during drowsiness and sleep, they are more activated. So you can see the runs are even higher. And this is associated even with slowing, that this happened in a patient who has bitemporal lobe epilepsy, where it's maximum on the left compared to the right. But in this specific EEG data that I provide, it shows the slowness of the left temporal chain with the spiky component in between during sleep stage. Frontal epileptiform discharges in comparison to temporal has usually maximum negativity in the frontotemporal, anterior midline, and frontotemporal area. Compared to the temporal lobe epilepsy, these discharges are less frequently observed, and mainly in the mesial area and the basal frontal area. And sometimes they spread very fast, especially the mesial one. So you can have bifrontal, and this is because of the secondary bilateral synchrony that we talked about. And that's why it makes frontal lobe epilepsy sometimes very challenging to lateralize. And you would need depth electrodes to further define where the discharges are coming from or the seizure onset. This is an example of a 16-year-old boy who had a left perinatal subdural hematoma and presented with uncontrolled epilepsy. And you can see here that you have sharp waves present at F3. And he presents with right hemibody tonic seizures that goes into right version and then right hemibody clonic. Occipital spikes are very well known to be age dependent. So you actually, in children less than 6 years old, they can be benign. And only 50% of those children who has occipital spikes can actually have seizures, while the others can have, or some of them can have visual problems like strabismus, amblyopia, or other vision problems. While in other children or older children above 6 years old, they are usually associated with vascular malformations, tumor, or cerebral agenesis. And if they have seizures, usually they would have some phenomena of visual complaints. And that's, for example, visual hallucinations or flight lights that happen on the contralateral visual field. But there are benign epilepsy of childhood with occipital paroxysms that are seen in children and that can happen after they close their eyes. And these are commonly seen in patients with migraine headaches. Surprisingly, the occipital spikes, although they are in the areas where we say are close to the vision areas or the vision centers, they are not photosensitive. So if you have photic stimulation to those patients, they would not have discharges. This is an example of a 40-year-old lady who is known to have myasthenia gravis and has also medical refractory epilepsy. And you can see here that she has frequent discharges at the posterior quadrant, mainly on the left hemisphere. And when we reference this example, it becomes very closely seen maximum at O1 and T5. This is another example of a 16-year-old boy with POLG gene-related epilepsy, and he has bilateral occipital discharges, so it's in the posterior quadrant bilateral, and his seizure semiology is left version that evolves into generalized tonic-clonic seizures. If we go more centrally to the central temporal areas, these are usually age-related. We see them between the ages of 4 to 10 years old. And they're not really highly epileptogenic, and that's why some of the neurologists would not treat every single child with Rolandic spikes. And the clinical syndrome usually consists of simple partial seizures where there is arrest of speech, some clonic activity in the face and swallowing changes, and then they go into generalized tonic-clonic seizures. And usually the distribution suggests a horizontal dipole where there's a phase reversal in the referential recording or two simultaneous phase reversals of opposite polarity in a bipolar recording. And this is an example of a 5-year-old girl who presented with steering events and was found to have these discharges that goes with centrotemporal spikes. The midline epileptiform discharges actually originate from the midline, and that's the vertex area. And this is an example of a 19-year-old lady who presented after a frontal lobe epilepsy surgery with a recurrence of her seizures. And you can see here that there's very nice discharges maximum at CZ that are seen here, and also when she has a seizure that originate from there. Now, if we go to the bilateral synchron epileptiform pattern, we said that although some of the patient would have a focal semiology or focal pathology, you would have bilateral symmetric epileptiform discharges. And this is actually due to the secondarily bilateral synchrony, where one focus would trigger another, and it transfers very fast through the transcallosal transmission or through the thalamus, inducing those bilateral synchronous epileptiform pattern. Actually, they further define this into primary and secondary, and some people try to define them further for other purposes, where they found that the primary synchronous epileptiform pattern usually runs at a rate of more than 2.5 hertz, while secondary will be less than 2.5 hertz. The discharges have the same morphological pattern, where it's more variable in the secondary one. There is more than one phase reversal in the primary bilateral synchronous epileptiform pattern, but it's single phase reversal in the secondary. And the primary seems more symmetric, while the secondary is asymmetric. Focal sharp transient are challenges that faces a lot of neurologists and epileptologists. And sometimes us as epileptologists, we will get a lot of patients that are diagnosed as epilepsy upon a finding of a focal sharp transient. So these discharges are actually, they do not stand up from the background. They look like spikes or sharps, but they do not carry the specific definition of it. And sometimes it is actually challenging because they would appear in the same place where your real epileptiform discharges are. So you can have them present in a real epileptic patient. And they can indicate some local hyperexcitability that are not suggestive of an epileptogenic focus, and you should not treat also. For example, this is an EEG of a patient who presented after an occipital ischemic stroke within 1 week with post-stroke seizures. And this was showed to me by the EEG technician as a suspicious discharge. But if you look at all the epileptiform or all the EEG, it looks spiky in nature. So then I would say this can be an epileptiform discharge. This area can be an epileptiform discharge. It does not much background, and it looks like part of the rhythm. So you have to be very careful. You can put it as a suspicion, but you have to look further and define if you're going to commit this patient as calling those epileptiform discharges or not. Of course, the history here is different. He came with very clear post-stroke seizures. So regardless of the EEG, you would treat in the acute setting. But in this case, I would not call those real epileptiform discharges. Now we talked that the polarity of most of the epileptiform discharge is negative. What about the positive interictal epileptiform discharges? These are rarely recorded, usually less than 0.03%, and that makes it a very rare phenomena. And those positive interictal epileptiform discharges have a high association with focal epilepsy and have to be differentiated from the normal variants. And why are they positive? And that's because of the orientation of the cortex and its neurons, and that's why it becomes as positive polarity. In children, it is very commonly seen, mainly in neonates, and that's because of their immature brain. Or it can be seen in newborns with intraventricular hemorrhage or periventricular hemorrhage, or with cortical malformation. In adults, though, it's mainly seen post-surgery. And it can also be seen when patients have depth electrodes for presurgical evaluation. This is an example of a patient who has left temporal lobe epilepsy because of left temporal ganglionioma. And you can see for surgery, he has very nice negative phase reversal as at FT9. After surgery, he presented again with recurrence of seizures. And when they evaluated him, his EEG showed positive polarity again at FT9. So this patient underwent another surgery and both positive and negative FT9 had disappeared. So the reason for his polarity here is because of the post-surgical changes and the orientation of the dipoles. If we move to a more complex discharge, and those are the periodic lateralized epileptiform discharges, over the years, they have been described differently. Between 1950s until today, the naming has changed and it has been associated with a lot of condition. Some of them had described the periodicity of it. Some of them had linked it to certain diseases like CJD. Some people have defined the intervals that you would not call it periodic lateralized epileptiform discharges unless the interval is at a certain percentage or a certain frequency. At the end, the American Clinical Neurophysiology Society had renamed it from the periodic lateralized epileptiform discharges to the lateralized epileptiform discharges. So what are they? They are EEG waves or complexes occurring in a sequence at an interval at a regular rate. And these EEG waves or complexes occur intermittently at approximately a regular rate of 1 to 4 seconds almost. They are usually focal or lateralized, and they can occur periodically. And they consist of spike, sharp waves, slow waves, or complexes occurring frequently, as I explained. They are mainly associated with an insult to your brain, whether it's a vascular insult, encephalitis, a tumor, abscess, a head trauma, or even in an intracranial operation, they would appear. Depending on the underlying process, they can evolve into other type of EEG abnormalities. And sometimes actually they are seen after a seizure or convulsive status epilepticus. PLEDs can be seen in patients with severe encephalopathy versus they can be seen in an EEG of a patient who is at his baseline. So that's why you have to correlate clinically. And because of that, it has been a challenge to call those as ictal or interictal discharges. Half of the patients who have PLEDs actually have seizures. Bipleds are PLEDs that occur independently on either side of the brain. While multifocal PLEDs, they would have to appear at 3 different sites on your EEG, and it's because of multiple lesions in your brain. This is an example of a 52-year-old man who had right temporal GBM status post-resection and came with altered mental status. And you can see here very nice periodic discharges on his right hemisphere, mainly on most of the occipital and the centroparietal area. This is another example of a 66-year-old man who came with remote frontal stroke, who came also with an altered mental status. And you can see here the periodic discharges is more of pulse spikes in comparison to the previous one. But there's also, and that actually occur in the frontal parasagittal area. This is an example of an 8-year-old boy with hypoxic ischemic encephalopathy secondary to a metabolic syndrome. And you can see here that the periodic discharges are actually independent of each other. So in the right temporal chain, they are happening, and they are happening in the left parasagittal chain, and they are independent of each other. So they are not triggering each other. Now, another new term that we have been using recently, mainly after we have correlated our continuous EEG with video recording and examining the patient while the video is running and while the EEG is running. And we found something called stimulus-induced rhythmic periodic interictal or ictal discharges. And these, so far, the pathophysiology is not really known. So this is, for example, a 37-year-old woman who's admitted with suprarefractory status epilepticus. This pattern has been induced after the technician has been tapping on her hand. So this would cause, so if you did not have the video, you would count this as a seizure and you will keep escalating her antiepileptic medication. Why do those periodic discharges happen? Glor and Gross suggested that the periodic discharges represent an abnormal response of the cortex, thalamocortical neurons, or both rhythmic burst firing generated by the reticular thalamic nucleus. Niedermeyer argued that the dysfunctional arousal is the primary abnormality or the primer mover in patients with primary generalized epilepsy. They tried to correlate, are those serpents related to seizures or not? And they found it's actually unclear. When comparing patients who had serpents and who did not have serpents on their long-term EEGs, they had no association between clinical seizures other than status epilepticus of any type. A correlation between status epilepticus and SERPIDs has appeared, but it's usually when it's a focal pathology. And they found that intracerebral hemorrhage appeared to be an independent predictor for the presence of SERPIDs, and that would actually always be focal, as ICH is usually a focal. Now, why would you have that? Why would you, when alerting a patient by any type of stimuli, you would have these EEG patterns? So whether the ones you see in SERPIDs, or for example, in starter-induced seizures, or infantile spasms, or like in CJD. This is because the theory is that arousal begins in the upper brainstem, especially the midbrain reticular formation, and that's mediated by the connection between the cortex and the thalamus. And experiments had showed that the cortical projections have profound effect on the intrinsic thalamic oscillations. So the evidence indicate that the behavioral state, and that's the arousal state, determined by those brain oscillations, is particularly involved by the thalamus through the thalamocortical projections, and in this arousal circuit is really very found in seizures. And because of that, sometimes an alertic stimuli can produce this EEG pattern or those seizures. And that's why we have to say that without very careful clinical EEG correlation, it would be very hard and challenging to recognize these patterns as a stimulus-induced pattern or state-related. The same lady that we talked about with superrefractory status epilepticus, these discharges had been induced by sound. So the technician very nicely had annotated this EEG for me to tell me why was this induced. So we do not call it, keep calling it. On the other side, he clapped at the bedside of this patient every single time, and this stimulus had appeared. And then this is on touching the patient, it induced almost that what looks like a very nicely evolving seizure. But this has not been there when the patient has been still without any stimulus at the bedside. So without a nice annotation by your technician or a nice video concentrating at the bedside, you would keep calling these seizures and you would keep treating them and escalating the medication. Now, clinical interpretation of epileptiform abnormalities. The finding of an epileptiform discharge is usually very specific for the diagnosis of epilepsy, but a single EEG, as Dr. Naim stated in his presentation, is not always sensitive test for epilepsy, particularly in certain situations. Only 50%, or as per Dr. Naim said, 40% of patients with epilepsy will have their first epileptiform discharge on a routine EEG. And as you do more EEGs, the yield become higher. Patients with mesial temporal lobe epilepsy may not have visible discharges, and that's why sometimes we would need sphenoidal electrodes to detect those. Frontal lobe seizures have low incidence of epileptiform discharges because of the mesial or the basofrontal area. Occipital spikes are not always associated with epilepsy because they are seen in patients with blindness and also with migraine. Elderly patients also have lower incidence of having epileptiform discharges on their EEG compared to younger ones. And sometimes there are limitations to the localizing value of the epileptiform discharges in certain brain areas like the interhemispheric fissure, the orbital surfaces, the mesial temporal, the occipital lobe, and the insular cortex. And location of the epileptiform discharges may not really reflect for you the real EEG onset zone, because some people would have multiple epileptogenic zones, or some people, the spread is very fast where it actually starts in a certain area because it's like higher epileptogenicity compared to where it starts from. And that's why you always have to correlate with your history, imaging, and seizure semiology to think, does it make sense or not? Now, what about when you find epileptiform discharges in patient who does not have epilepsy? What does that mean to you? For example, an EEG was done for a patient with headaches or any other reason that sometimes you would see it's done, and then you would find epileptiform discharges. It is not rare. Less than 2% of people who have epileptiform discharges on the EEG would not have epilepsy, but most of the time it is actually found in patients who have some sort of a progressive cerebral disorder. The type and the location are indistinguishable in patients who had a pathology in their brain versus not. But the risk of having an unprovoked seizure for such patient is actually low, and it's up as low as 6%. And that does not warrant starting prophylactic medication if you did not have actually a seizure. Finally, I would say that the International Federation of Clinical Neurophysiology had put a criteria for defining interictal epileptiform discharges. This study was very nice because it looked into how is the diagnostic yield of using this criteria to define epilepsy from discharges from sharp transient. And they used sensor space and source space to look into those. And they had a few of, they were trying to look at the interratal agreement between multiple epileptologists. So they gave them 100 EEGs of people who had real epilepsy or non-epileptic seizures versus epilepsy from discharges versus sharp transient. And they use these criteria to see what is the inter-rater agreement. This is what they found. They found that there was a very high inter-rater agreement between the epileptologists on defining an epilepsy from discharges when it reached these three criteria: that they have a spiky morphology, that the wave duration is different than the background, and it's followed by a slow wave. While they found that the inter-rater agreement was moderate when they say that there's a polarity. Distribution of the negative and the positive potential suggests that it has a source. While the inter-rater agreement was found to be fair in defining the epilepsy from discharges as asymmetry of the waveform or it stands from the background. But they found that the area under the curve was close to 1. And that means that this criteria is very good diagnostic criteria if you use at least 5 of them to try and differentiate between epilepsy from discharges from sharp transient, as the area under the curve was almost close to 1. So you can use this criteria for helping you to define when you're not clear if it's an epilepsy from discharge or not. And finally, especially for residents and fellows, this has been released recently this month, and it has a very nice example of defining the terminology of epilepsy from discharges and other, and it can be a very helpful source for you while reading your EEG. Thank you so much.
Thank you very much, Dr. Haifa, for this very, very amazing lecture and comprehensive, mashallah. We have to limit our Q&A because we are so much over time, unfortunately. I'll start by my questions for you. I'm so interested about when you mentioned about secondary bilateral synchrony, and I'm wondering, do you know the reason why they classify it as secondary and primary? Is it is any clinical significance in our reading between them?
I don't think there is any clinical significance from our point of view in terms of, for example, management or defining them. It's actually not clear why they define it this way. So actually, I'm not sure about that.
Okay, good. Great. One of our attendees asked how much 3 Hz spike and wave can be revealed in other condition other than typical absence seizure?
Actually, I saw it in multiple of my patients who had generalized epilepsy that did not have much of absence, but had other semiology. So we cannot actually, per our reading and per the articles and per our studies, it is a lot linked to absence epilepsy, but you can actually get in other types of generalized epilepsy. And I had noticed that myself, especially in long-term EEGs in epilepsy monitoring unit, where you see it very clearly, but the patient would have a different semiology. And then you would go back and you say, okay, maybe I missed this semiology. Maybe he has those small seizures that are not noticed, but there's a clear, saying that I don't have it, and the family would confirm that too.
Yes, I agree. It's mostly suggestive of primary epilepsy, not only the juvenile or the absence. Okay, great. That other question from Sumaya Bajamal. She's asking, what is the clinical significance of cerbits? It's really a very nice question.
It is a very nice question, actually, because there are certain areas or certain hospitals that do not have video long-term EEG monitoring. And because of that, those patients would have, you will count, for example, 16 seizures in whatever hours you did, because you don't have a technician there to annotate for you and you don't have a video. I think the clinical significance of it, from my point of view, is that it's stimulus induced for whatever reason. But I would like to know if they are like, I would need to treat it or not. So the clinical significance would be for the epileptologist. Usually, most of the time, I notice it in that are in patient with a very bad cerebral pathology and would end up with a poor prognosis. But I cannot comment that it will be on most of the other patients. But that's where mostly I saw it, like post-hypoxic encephalopathy or a very bad insult to the brain for any reason, is where I usually saw this pattern.
Great. Larry Shan asking, do you consider TERDA without other epileptiform discharges epileptiform? If so, will you start treatment for patients with first seizure and TERDA?
If I have a very clear history of the patient, because sometimes you would actually have patients who would tell you this is my first seizure, but they miss a lot in between, and that's why digging into the history, as Dr. Naim Haddad said, is very important, as some people would have nocturnal seizure that they would not define. And so I would actually keep doing, if I had TERDA and I had a brain pathology on imaging, I would start treatment. If I had TERDA and only a one seizure, I would wait if I don't have a very significant history. I would not commit a patient only on TERDA to start antiepileptic medication after a first seizure.
Okay, great. Last question. He's saying this is excellent presentation as always, Dr. Haifa, and he's asking, what is the importance of the post-ictal EEG attenuation? Is it localizing or not?
Which one, sorry?
What is the importance of post-ictal EEG attenuation? And is that attenuation localizing or not localizing?
I don't think it's the attenuation. If he means the EEG depression, or some of the term is called EEG depression. Actually, it actually tells you it's a generalized tonic-clonic seizure, and most of the time they have higher risk. Per the studies of SUDEP, was found that post EEG generalized EEG suppression is associated with SUDEP, but I don't think it has a localizing value. The one that has a localizing value is the EEG slowing, that is focal after the EEG, the focal one. But the generalized EEG suppression or attenuation does not usually give you a lateralizing value.
Great, Dr. Haifa. Thank you very much for this excellent talk. And we hope all you good night. Thank you.
Thank you.